Greetings from England, the most politically exciting country in Europe these days. It used to be Greece, but we're no longer the odd one out. It is England these days. Let me start by sharing my screen and my slides. So what I'm going to do very briefly is to reflect on how we can generate value through innovation, taking a global and national perspective. So we'll focus on two major challenges. How can we improve global governance? And then how can we improve national responses to enhance health systems resilience and efficiency? Let me start with the global health governance perspectives, because there are lots of discussions now at an international level to reform global governance, starting with a proposed pandemic treaty. There is an intergovernmental body now established by the World Health Assembly of the World Health Organization to discuss the possibility of introducing a pandemic treaty to strengthen prevention, preparedness, and responses. I have many doubts as to whether WHO will manage to establish this treaty, because might be perceived as very restrictive by a number of international global powers, such as the United States of America, China, and Russia, which may not want to have a standard treaty in place, and the possibility of intergovernmental organizations such as WHO to interfere with their responses in terms of tackling new pandemics. Then we have the responses of the G20 and the World Bank. The World Bank is establishing a pandemic preparedness and response fund, a mega fund, which is not going to involve the World Health Organization and other intergovernmental and international bodies. Now, it remains to be seen how this is going to be managed by the World Bank without involving the key intergovernmental health organization, WHO. And then the G20 are also proposing the Finance and Health Board, and I think this is a reasonable proposal, to build on the G20 Joint Finance and Health Task Force. So we do desperately need to bring together the finance ministers and the health ministers to tackle global health policy issues together, including antimicrobial resistance and also climate change, and take an One Health approach, not only a health approach, but also focus on One Health involving climate change. And finally, the European Commission and the United States of America are proposing international health regulations reform to make them more relevant, move beyond the current name and saying. And again, it's not certain as to what extent most countries at the World Health Organization level will accept a strengthening of the international health regulation. They may conceive this, they may consider this as interference with their national policies and their flexibility to act according to their national priorities. We also need to have a global pandemic vaccine policy. We don't have a global vaccine policy. We don't need to have a treaty here. Well, we do need to have an agreement to stimulate and enhance innovation in terms of producing new vaccines, not only for the current pandemic, but also for future pandemics, and also at the same time ensure the availability and the distribution and the equal distribution of vaccines. Because we know that there is significant inequality between the North and the South, but there are also significant inequalities within the North and within the South. Now, what about the European responses? The EU response to COVID was initially a series of knee-jerk reactions. But currently we can see a more strategic development of policies. And the most important innovative reform and policy within the European Union has been the development of HERA, the Health Emergency Preparedness and Response Authority. Now, HERA is going to be a program, not another agency within the European Union, accountable to the Directorate General of Health, not independent therefore, responsible for horizon scanning of future threats, responsible for financing the development of therapeutics and vaccines to address emerging and new threats, and also for enhancing production of vaccines and therapeutics within the European territory. However, it's going to be one of the agencies and programs within the European Union where there are a number of other initiatives. The European Centre for Disease Prevention and Control needs to be enhanced and become pan-European, not only a centre for the European Union to involve Great Britain, for example, the countries of the European Economic Area, and many countries from Central and Eastern Europe which are not part of the European Union. Then the coordination with a civil protection mechanism and the European Medicines Agency needs to be clarified and enhanced. And also coordination with the Directorate General for Research and Innovation of the European Union, because they would also be funding research and development for new therapeutics and vaccines. So we can see here a positive development at the European level, a new program, but lack of coordination at European level in terms of getting their act together to bring the different bits and pieces in terms of policy development across all aspects of European health policy. But what about national responses to our challenges? So we know multimobility is most common among older people. The number of mobilities and the proportion of people with multimobility increases substantially with age. By age 50 years, half of the population have at least one morbidity, and by age 65 years, most are multimorbid. Fine, but that's not a good argument for the ministers of finance and the prime ministers. If we're going to invest more money in health, are we going to invest more money for the older people and then less money for the more productive people, the working people in our societies, less money for education, for example, or retraining of the working age population? But we also know that the prevalence of multimobility increases with age, but the actual number of people with multimobility is higher at younger ages. So you can see here data from Canada, and I'm presenting very old data, and I'm doing this on purpose because this data exists and politicians don't take notice. They think that multimobility is only a problem of the older people, but the prevalence of multimobility is in the working age population, those between 30 and 65-year-old. But what is the impact of multimobility? We can see it here, again, from Canadian data. I can present you data from Germany, Britain, and many other countries in the world. 1% of patients every year consume 33% of total health spending. 5%, 65% of total health spending. And 10%, 70 to 75% of total health spending. It's 70% in Britain, 72% in the United States of America, and this particular province in Canada is 75%, 77%, probably because of epidemiological trends and demographics. But what is important is that these complex high-cost users receive treatments from multiple healthcare sectors and providers, have long lengths of stay in inpatient settings, very expensive settings, see 6 or more physicians a year, 75% of them, and 25% of them seeing more than 16 providers a year. And if we look at the wealthier healthcare system in the world, the United States of America, the US is spending 18% of their GDP on healthcare. You can see the results of this fragmentation in healthcare systems. We're talking about innovation, but we do need to address, as an innovative policy, the fragmentation in our healthcare systems. Less than 50% of elderly patients are up to date on clinical preventive services. Elderly patients with comorbidities, with at least 2 diseases, consume up to 19 medication doses daily. You can understand what happened here in terms of drug-to-drug interactions and unnecessary hospitalizations. Every year, the average elderly patient sees 7 doctors across practices. The average surgery patient is seen by 27 different healthcare providers. 1 out of 5 elderly patients are readmitted within 30 days, and less than half of non-surgical patients follow up with their primary care doctor or provider after discharge from hospital. So this is a catastrophic scenario. If it continues in the US, they will spend 25% of their GDP by 2030. They might be able to afford to do that. They're the wealthiest economy, still the wealthiest economy in the world. But countries such as Greece or Britain and many other countries in Europe, they won't be able to afford to spend 30% of their GDP on healthcare. So therefore, we do need to think out of the box and address the current inefficiencies in our healthcare systems. What are the current inefficiencies? We're treating people too late. Sometimes we don't know which interventions work, in which setting, and which don't work. We treat all patients in the same way. Errors, which are mostly system errors rather than medical errors caused by doctors or nurses, are often unnoticed. So it's the way the system operates and structured. There's huge variations in healthcare quality, not across countries, but also within the same country, within the same region, within the same hospital. If you compare cardiology clinics in the same hospital, you will see there are huge variations in healthcare quality. We have non-sensible workflows. We make our patients arrive at our silos, the cardiology silo, the respiratory medicine silo, the nephrology silo, the oncology silo. And finally, we're not engaging with our patients and they're ignoring our advice. 50% of asthmatic or diabetic patients are giving up medication 1 year after they have been diagnosed with asthma or diabetes. So we do need to be more proactive. We need to have a more proactive system in terms of diagnosis. Early diagnosis matters. It can be cost effective, but here we do need to go beyond primary prevention to have a better system of secondary prevention, which is clinical, and tertiary prevention in our healthcare systems. Need to make better use of real-world assessments and real-world evidence. Now, the European Common Data Space, enacted by DG Sanko and Commissioner Kyriakidis, has to be translated into the Greek environment in the form of a national strategy for digital policy and digital data, which is currently lacking in the healthcare sector, and it has to be developed over the next few years. I'm not in favor of revolutions in healthcare systems, but I'm in favor of a pragmatic incremental change. But in order to have pragmatic incremental change, you must have a plan. Then we do need to move into personalized medicine, but I think we'll have the last intervention is going to be about that. I'm not going to spend time on this, and have a system that will be based on a safe and monitored environment. Improve quality of healthcare, but in order to do that, we may need to make better use of big data and better use of decision support systems for our doctors, nurses, and healthcare providers. Not to substitute clinical acumen. I don't believe that better informatics and better use of big data will substitute for clinical acumen. We definitely need to have good doctors in place and well-trained doctors in place, but at the same time, we need to support their activities with big data and better guidelines based on the best clinical evidence. And finally, better integrated systems that will engage with our patients. So we need to break down all these silos and focus on these high-cost vulnerable patients, integrate primary care with pharmacy care, with secondary care, tertiary care, and long-term care, particularly for these 10% of the high-cost, high-need patients. And finally, we need to blend the human and the technological capabilities in our healthcare systems. We're not doing that. The expected prevalence of virtual healthcare by 2026 is going to be significant. You will see in particular this will happen in dermatology or primary care for the first contact interaction visit, but not as much in oncology or gynecology, for example. It will be significant for long-term follow-up and continuing care. So we need to grasp all these emerging opportunities in terms of using digital health, integrate digital health providers, which are currently scattered. They're not integrated with the formal healthcare system, and there is a risk here. There is a risk of adverse selection. And what is the risk of adverse selection in healthcare systems? The younger people with very low needs to use virtual healthcare, and then the older people with the actual needs to use the traditional care. So therefore, we need to blend the two systems. And I'll finish with this observation.